Welcome everybody to a special installment of UnEDited. I'm Ed Fry, president of ACC. We're coming to you from ACC 2022 Legislative Conference taking place in Washington, D.C. And it's a real pleasure for me to introduce today's panel. First, Dr. Sam Jones, who is chair of the Health Affairs Committee and a practicing electrophysiologist from Chattanooga, Tennessee. Dr. Melissa Wood, who is chairman of the Board of Governors and a trustee of the college. She's professor of medicine at Massachusetts General Hospital. And Dr. Melvin Eccles, who is ACC's Chief Diversity, Equity, and Inclusion Officer. He is a heart failure specialist and is associate professor of medicine at Morehouse School of Medicine. So thank you, Sam, Melissa, and Melvin for being here. And what we're hoping to do today is to really have an open and freewheeling conversation as it relates to advocacy. Each fall, we come together in DC for the legislative conference where we talk about current issues, and we have specific advocacy issues that we bring to legislators and regulators on the Hill. This is a particularly meaningful year since this is a very important midterm election year. And we're very excited to have the opportunity to talk to legislators just in advance of the election. Some of the issues that we deal with are big and broad, and some of them are very focused, but some of the specific broader issues are societal, related to health equity and inclusion. Some of the issues are also very timely, related to post-COVID recovery, the issues of maternal health obviously being an important one. So each of the individuals who are on our panel today are very intimately involved in this process of both advocacy and developing policies and advocacy positions for the college, and we'll hear about their role and their experiences. So just to kick things off, Sam, you lead the Health Affairs Committee. Tell us a little bit about the HAC and its role within the college, and how advocacy issues are brought forward to the HAC and how you approach them within the committee.
Sounds great. Thanks so much, Ed. And we are so excited about Legislative Conference. So I am the chair of the Health Affairs Committee. We are a 22-member group. We are ACC members who take time out to work with the policy directive for the college. And essentially, this comes up to us from members from the college. This can be individual members that have something they want to discuss. Frequently, it actually comes to us from the Board of Governors, where there is something that arises in a specific state or something that we need to address. And there's a multitude of ways that we try to address this. It can be through state advocacy. There's a lot of different things that are going on there, whether it can be with restrictive covenants or tobacco laws. There's a whole host of things. Obviously, on the federal front, we try to deal with things in terms of the CMS laws as an EP. There's a lot of issues going on with reimbursements right now, and this will be some of the things we talk about this legislative conference. We deal with FDA. We deal with some of the other agencies. We deal with private payers. So a lot of things that come up with private payers, specifically prior authorizations. That's something that our members talk about constantly. In fact, that's probably the #1 issue that comes up. And then we try to deal with issues of disparities in care. And so wherever these issues come up, our health affairs try to look out. We work very closely with the ACC advocacy staff. I always say the best staff in the business of any medical organization, and we're blessed to have them. And with them, we try to develop different policies or work with other stakeholders to see what we can do. Typically, we know there's the cardiology world we live in, and then there's the cardiology world that we want for us as clinicians and for our patients. And our job is to try and move it to the world that we want to be in. I think our clinicians know that there's a lot coming at us right now, and we really sense that people want to be engaged, they want to make a difference. And this is the time, as you referenced already, for that.
Well, as you mentioned, there's a lot on your plate, and there's even more that's brought to the hack that obviously has to be in sort of a queue, and we can only sort of deal with so much at a time. But tell us, what are sort of the hot? You alluded to a few of them, but what are the hot button items, and particularly what are the specific asks that we're going to have this year at the legislative conference when we talk to legislators, and what's sort of some of the background blocking and tackling issues that we bring up every year to regulators and legislators?
Yeah, thanks, Ed. I think that what we try and do in the Health Affairs Committee is to tie what we do to the strategic direction of the college, and what is it that we need for the cardiovascular patients and for our clinicians. So number one right now, the number one thing is financial stability. And we know that we are getting bombarded from numerous angles right now in terms of cuts. This can be a conversion factor cut, a PAYGO 4% cut. And so this will be the number one thing that you hear us talk about at legislative conference. And this isn't really about the physician payment as much as it is the patient access to care. And this is how we frame everything. What is the cardiovascular patient access to care? And we think that Congress and CMS has to understand that if they continually cut down these payments, it's going to affect our patients. And this just isn't right for the system. You know, right now we live in a very crazy world. This is no way to run a healthcare system where every year, at the end of the year, we're going to Congress and saying, you can't cut this. And we should be doing better than this. This is not a way for us to really be addressing this. We have other things that we could be doing to really advance causes, to be addressing disparities in care, to really get a meaningful system. So our number one thing will be, how do we reform the system? Short term, we've got to address the payment cuts coming, but long term, we need to look at ways to make the system better. So you'll hear a lot about that, whether that's making sure we get inflationary increases. Every other aspects of medical care gets that, but physicians don't get any ties to inflation. That's wrong. Over 20 years, you actually see that we've dropped off 20%, where that doesn't happen anywhere else. Budget neutrality, that affects us more than it does anywhere else. And the administrative burdens are just unbelievable. We feel that every day. And that really probably goes to my second thing that you hear us talk about, the clinician well-being. There's so many things that are tied up into that, but I go back to that prior authorization because that's the number one thing that we hear from members. And so one of the bills that we're going to be asking our Congress to look at is a bill that looks at prior authorizations for Medicare Advantage members. How do we make sure that this is a more rational approach? How do we make sure that there's some transparency to it? And how do we actually streamline that process? That's very important. Along with clinician well-being, we also know that there have been numerous acts of violence that have been really targeted toward nurses and toward clinicians. And that's just unacceptable. Of all the things we have to deal with, we shouldn't have to be worried about, are we safe at work? So there's an act called the SAVE Act that we're going to be looking at. The other thing that we talk about, really along with patient access to care, is the cardiovascular team member. And I think that the ACC does a phenomenal job about ensuring that we really think about the cardiovascular team, because this is how we're going to have to approach cardiovascular care in the future. The reality is we have a gray tsunami coming, right? You look at some of the hair that maybe we both have here, over 50% of cardiologists over the age of 55 right now. We have got to make sure that future generations have that cardiovascular care. And we have not as many trainees coming into that are going to be able to do that. We have a supply demand mismatch in terms of workforce. So how are we going to help that out? It's with cardiovascular team members. How do we make sure that the barriers are reduced where appropriate for that? And one of the ways we feel that is with cardiovascular rehab. So one of our bills actually addresses that, to allow advanced practice practitioners to be able to both order and supervise cardiovascular rehab. And this is something that we really like to talk to our Congress staff members about because it's such an important therapy. And any way we can reduce those barriers to care for that is extremely important. And the last thing that we'll talk about is science, because I think ACC always talks about science is what we are known for. And we have two bills that relate to that. One is the South Asian Heart Awareness Bill. And the second one will actually relate to valve research, cardiovascular research outcomes. And it's named after Carroll. It's the Carroll Act. Representative Andy Barr in Kentucky, his wife, unfortunately passed away. And this bill is named in honor of her. And it goes through valvular research. How do we make more awareness of it, and some more funds being devoted to the research of those conditions.
Great. Well, that's a great overview, and certainly should whet everybody's appetite in terms of what's going to go on at the conference over the next couple of days. Melissa, you chair the Board of Governors, and also you're a trustee, so you have a very broad perspective of what's going on in the college, and particularly the membership, and the Board of Governors being the direct conduit, the direct connection to the chapters and to the members. Tell us how advocacy issues are brought up, discussed within the Board of Governors. I know there certainly are no shrinking violets there, and there are robust discussions that take place online. But tell us how a specific topic would come to everybody's attention, and how you would discuss it, and how would you formulate it, and then perhaps pass it on and work in conjunction with the hack.
Sure. Well, thank you, first of all, for including me today. It's really exciting to be here. You know, and we have several mechanisms for really hearing about issues that are important to our members. You know, one is that the members will reach out to their respective governors, and then the governors will post something on our listserv. As we know, the listserv is very active, and a number of very important legislative topics have really come to the forefront through the listserv mechanism. And then we are really able, as part of the Board of Governors leadership, to reach out to Meg, Lucas, Nick, and their teams to really find out more about the issues. You know, many times we'll hear about a bill that a governor or a chapter or member will be interested in, and then their team, the advocacy team, and I agree with Sam, they're the best staff in the world, amazing individuals, and they will learn more about the bill, some of the finer points and how it really does relate to cardiovascular care. And oftentimes, if these bills or pieces of legislation are felt to be very important, we will really elevate those further and think about whether or not we need to set up, their team needs to set up meetings with some legislators to really advocate on behalf of the college. Certainly, some of the topics that come up will have importance at the federal level, and then other topics will really be determined more at the state level. And we actually most recently had a work group devoted to state advocacy issues and best practices, so that we could really implement strategies in our chapters to develop approaches to really reach out to state legislators and partner with state medical societies in those particular topics that are really state-based. We know, and we've all participated in legislative conference, and we recognize how robust our advocacy program is at the federal level. But I think in many situations, our state chapters have not been as adept at taking advantage of some of the resources that the college offers. And the goal of that work group was really to make those resources more readily available.
The chapters and the governors have done a great job in terms of being the voice of the members and really helping to be that connection. You know, Melvin, many of the advocacy issues incorporate the concept of equity, and we use the term equity a lot, but within the context of the advocacy work that's done through the ACC's advocacy staff and through the Health Affairs Committee, what does equity mean, and how should we interpret what equity means when we talk about those kinds of things?
All right, great. Thanks, Ed, again for having me. So, you know, I think that before we think about what equity means for us as an organization, we have to really sort of consider what advocacy means. And advocacy for me is sort of the action or the deliberate effort to actually get to the equity, or which is the outcome. And so, as you very well know, advocacy can mean many different things for many different levels, just as equity has the same similar definition. I don't think that, there is any lack of inequity in cardiovascular care that we've seen on a federal level, on a state level, and even on a, local community level. And so the question is, what are we actually trying to do to get to the outcome that we specify or we desire? And so I could not agree with Sam more. It really is related to primarily access and patient care, patient management. And that sort of ties closely into how providers are treated, how providers feel in terms of going the extra mile and doing the work and getting the reimbursement for their care. But, I think that, we have a bigger issue here in terms of what we're really sort of considering. And, equity, again, for me, I think on the federal level means, making sure that, again, as the committees have actually suggested, bringing forth these very great, great bills and policies that we hope to move the needle over time. But again, speaking with Nick and talking with Melissa, I think some of the work actually still lies in the local community and the state chapters. The state chapters have a lot of power in terms of policy development and sort of change on that local level. And then, I tend to think, again, advocacy means really sort of hitting the community. And we tend to think, advocacy may be legislation or not, but really advocacy can mean anything that you're doing to sort of go the extra mile to provide that equity or that outcome. And so that means, community awareness. That means developing pipelines. As Sam actually suggested, we are, heading towards a deficit in terms of providers. And so if you're able to sort of help with providing providers what they need to actually sort of reach their best optimal sort of self, I think that's kind of where we are. And that's really what we consider equity. Equity is not providing everybody the same exact thing. Equity is providing what a patient needs to make sure that she or he actually is able to fulfill their optimal health.
Yeah. Well, Melvin, I wanted to ask you one other question. Kind of goes back to something that Sam said really at the beginning, which I think is so important, which is, when professional societies talk about advocacy, outsiders, the first thing they think of, oh, well, it's just very self-serving. And I think you alluded to the fact that, perhaps there are constituencies of patients that we see or groups of patients that we see who need us to be their advocates. Maybe expand on that a little bit. I think you touched on some of those things as it relates to places where access isn't available or resources aren't available or services aren't available.
So, you're exactly right. So basically, there are certain populations that actually suffer from huge issues in terms of access, whether it's related to insurance or actual just kind of therapies in their area. And this can mean anything from, urban settings to rural areas. So rural areas, they may have the insurance, but they may not have the providers that are able to sort of offer the advances and that they may need. And so it sort of, when you're thinking about different populations, I think what is really important is to make sure that there is an assessment first. I think on a state level, it's very important for the state to actually assess what populations are the most disparate and where are the major health inequities. Before you can get out there and start sort of, advocating for change and advocating for action. Because one of the problems that I have is I do not want to get into a situation where we're just doing things just to do them, just to say that we're promoting health equity. You really need to think about the assessment and the evaluation, what people really need, and then the strategic effort to actually get to that outcome. And so that's very important for me when we're discussing diversity, equity, and inclusion.
That was really helpful. One of the things that's been probably one of the most controversial things that's happened in the last 4 to 6 months or so was the Supreme Court decision related to Dobbs versus Jackson and the impact on availability of certain reproductive services for women, particularly those with cardiovascular disease, who we know represent the majority of people who have maternal mortality and morbidity. And this has been an area that the Board of Governors, I think, has been very impactful in. And I know, Melissa, you led a lot of the work related to the college's advocacy approach. And you mentioned earlier that in addition to these national and federal level initiatives that we have, the college is very much engaged in state advocacy. And by nature, through the decision, these policies and issues and laws, legislation have been thrown back to the states. So tell us a little bit about your experience in terms of dealing with this and how you worked with the Board of Governors and how you're working with the ACC state advocacy group.
Well, thanks, Ed. Yes, this has been a challenging time, in particular for those of us who are actively involved in the practice of cardio-obstetrics. But I think it's important that we all take a step back and realize that anyone practicing cardiology will likely come across a patient who either has experienced cardiovascular disease during pregnancy or may be at risk for complications of pregnancy that are cardiac in basis. And so I think we all need to familiarize ourselves with some of these fundamentals. And I think this issue in particular, which is, as we know, going to be it legislated at the state level, has really shone a light on how we need to develop stronger relationships, both at our state house, with our state elected representatives, with our governors, and absolutely with our state medical societies. And the Board of Governors quickly stepped up to the plate, as did ACC leadership, to pull together a series of resources, including some guiding principles and member guidance. And the guiding principles were really just the reminder that we are a member-led organization and that we are here to transform cardiovascular care and improve heart health. And we certainly want to maintain health equity. And one of the leading tenets of that is that we really want to maintain patient-centeredness in the way that we deliver care. So the patient needs to be in the middle of every important decision we make as the cardiovascular team. We really want to stress the importance of shared decision-making, both throughout pregnancy and afterwards for women who had cardiovascular complications during pregnancy. And we really stress the importance of understanding the individual laws in each state and what our chapters can do to educate our legislators about this looming health crisis, which is maternal mortality and maternal morbidity associated with cardiovascular disease. So we know that, right now in the United States, cardiovascular disease is the leading cause of maternal mortality. We recognize also that many are caring for these women in a void or vacuum and out in the rural areas or in very small systems. And we want to educate our members about the ability to use things like telemedicine to really expand care to those in the community. And finally, we recognize the importance of working with other healthcare groups within our states to really work to advocate on behalf of our patients. I also really want to highlight the work of the Cardio-Obstetrics Working Group, which has, with the Cardiovascular Disease in Women Committee, written over 18 and published 18 manuscripts in the past year devoted to maternal cardiovascular health. And on November 18th, there will be a virtual program, The Essentials of Cardio-Obstetrics and the Importance of Team-Based Care. And I strongly want to encourage all of our members to participate in that program because I think they will be touching on a number of important aspects of care of women during reproductive age time. So anyway, a lot of things happening. BOG has really tried to support our members through education and ongoing advocacy. And I really appreciate, Ed, your efforts both in pulling together some of the recent former presidents in writing a leadership page and then working with Dr. Walsh, myself, under your leadership to really pull together a formative statement that was published in Jack recently as well.
I think you bring up two really important issues here. Number one, just going back to the cardio obstetrics work group, I think a lot of people's idea of what goes on in the advocacy work that the college undertakes is that it is so far removed from education and science and clinical questions that we deal with. This is a great example of how these resources within the college really kind of get married up and really complement one another. I mean, I think the message coming from the advocacy group around these issues would not be anywhere as strong or loud were it not for the scientific foundation and the educational foundation. And as you said, really big role was to educate the legislators. And then the second thing was you alluded to, and I'll ask the others to comment on this too, but the issue of collaboration, cross society, cross organizational collaboration. I would say many of our most successful ventures have been when we bring in other voices. And this is why it's so important why we have try to have as unified a voice within the House of Medicine as we can. You know, legislators they're doing their job and they have limited understanding of what's going on. And if they have 10 different medical groups come to them with 10 different views of the same topic, they come away more confused than they were at the beginning. So I think that's a really important concept. Melvin, I wanted to go back for just a minute to certainly one of the important considerations related to equity is understanding the social determinants of health. And maybe you could give us some examples of advocacy efforts that can sort of address some of these. They may not be immediately tangible in terms of medical considerations, but as we know, probably 80% of a patient's outcome is the result of the negative impacts and on a more optimistic level, the positive impacts of their social determinants of health. So what are the places where advocacy can really play a role in terms of impacting that part of the equation?
All right, great question. So, I think that the first sort of step is just kind of understanding what I classify as the traditional versus the non-traditional social determinants of health. As we often think about social determinants of health in terms of food insecurity, education level, income, transportation, all of those things, those are long since, I think, studied in terms of looking at the predictor risk for CVD. And most definitely there are significant issues, but then there are the non-traditional that we're starting to embrace in terms of the systemic discriminatory issues that actually historically marginalized groups have to face. And I think that those have just as much of an impact, if not more, on a societal level. And so I think it's very important to understand these issues. In terms of things like the traditional social determinants of health, so let's take food insecurity. So one of the great programs, ACC has many programs, but Caring Hearts happens to be one of them that actually is a very wonderful program that actually helps to provide services in terms of food and things of that nature for people who otherwise would not necessarily have the access to food or the proper food. I think that there are a number of other initiatives that we actually do and we should do on a local level, meaning a community level, that often tend to be really effective when we're discussing, things like transportation and education, things of that nature. But, when you're talking about sort of on the federal level, I think that we all must understand that a lot of the social determinants of health actually can be, improved with access. And so that's why access to care is again, the most important thing for me, making sure that people actually have the resources as well as have the availability of services that they need.
Great. Yeah, many things that occur at a governmental level will have that sort of direct or indirect impact on health. Well, Sam, we have just a couple of minutes left. Maybe you could wrap things up for us in terms of why should ACC members become engaged in advocacy, and why should they not fear? I think there's some inherent sort of either lack of confidence in terms of engaging in advocacy, or a lack of familiarity. Tell us, how should members engage, and why is it so important for them to do so?
Yeah, thanks, Ed. This has been great. And I really appreciate listening to Melissa and Melvin. I think that the first thing I will say is that I know a lot of very passionate, phenomenal ACC members, cardiologists, and CVT members. I don't know any of them that say, boy, the system is great. Everything's fine and dandy. I think we shouldn't change anything. Everyone knows we can do better. We can do better for ourselves, and we can do better for our patients. But nothing's going to change if we don't get out there and do something about it. And that takes us activating ourselves. It takes us getting energized. It takes us going out there and having a voice. And I think that's the first thing I would say. If you think the system's great, you don't have to. But if you think the system needs changing, if you think that we can do better as an organization, then let's do something about it. If you're worried about it, understand that there are phenomenal people in the ACC that will guide you through it. We talked about the staff already. They walk us right through it. But there are senior ACC members that have been doing this for years. And as a fellow in training, you may say, I don't think I can go up there and actually do this, but they're never going to put you out on an island, just like they didn't when you did training. They're going to have someone there just to walk you through it. And the time is just really getting critical for us to do this. Increasingly, we're getting bombarded, whether it's financial, whether it's the regulatory, whether it's electronic health record, whether it's insurers, so many people trying to tell us what to do and trying to say, what is value-based care? Well, we're the ones who determine what that is. We're the ones who determine what quality is. As they put more and more pressure on us with the payment cycle, we have to be the ones who are the guardians of that. And so I really encourage everyone, and I would want to thank everyone who takes time out of their schedule to come to legislative conference, or even just at home, those who are doing there, because as been stated already, advocacy is something that's not done just on the legislative conference. This is something that's done 365 days a year. It doesn't have to be at the federal level. This is going to be something that's just done at your local community. This is going to be done in your hospital, with your department, on multiple levels. So there are plenty of ways to get engaged. And with all of us banding together, we always say, if you're not at the table, then you're on the menu. It's time for us to make sure that we're standing up and we change the system.
Those are all great points. And that's a great way to end this really helpful conversation. I really appreciate it, Melvin, Melissa, and Sam, and just to all of those who are attending the legislative conference and those who will be listening to this later on. Again, get engaged. Don't be put off. Don't be intimidated. And there are many ways you can do that. Certainly, the easiest is working through your chapters and working through your local advocacy efforts. Participate in the committee structures that also funnel into the advocacy agenda, and then support the PAC. And ironically, PAC means Political Action Committee. It is the most apolitical body it can be. It is a bipartisan, agnostic body that really is there to help us gain access to the ears of legislators and rulemakers, so that we can advocate for our patients and for our profession. So please support the PAC as well. And there are many resources on acc.org. Make sure you access those. Again, thank you to our panelists today. Really a fantastic discussion, and can't thank enough our very professional ACC advocacy team, who are the envy of the House of Medicine in terms of their experience and their skills and their ability to transform our message into actions. So again, thanks for everybody, and have a great rest of the day.